TopMedTalk.
This is TopMedTalk here at Euroanesthesia 2023. I'm Desiree, Chappell, your host today, and Monty Mythen. Hello, Monty.
Hey, Desiree. Oh, hang on, the pipers are cutting back in.
Here they go. We're gonna. Oh. Well, I think actually it's very fitting. We have them playing while we're talking about being here in the exhibit hall, Monty. Some wonderful booths. Today, here, the very first day of ESA, we have the privilege, the opportunity to be with GE Healthcare, one of our platinum sponsors for TopMedTalk.
Absolutely. Very generous, loyal supporters of TopMedTalk. And just to reiterate, it wouldn't be possible to keep this as free, open access medical education for the world if it wasn't for our great sponsors. Yeah, and recently, GE, who used to sponsor us, transitioned into GE Healthcare, which we heard about particularly at the American Society of Anaesthesiology at the back end of last year. But more about that in a moment, I'm guessing.
Yeah, we definitely will dive into that. Monty, this is our third year here at the European Society of Anesthesiology and Intensive Care Euroanesthesia meeting. Prior to COVID, we were here. Last year, we were here as well.
So we're in Vienna.
Yeah.
And we're going to catch up with some people that we met in Vienna talking about projects that they had planned at that stage. Now, some of them got COVIDed, but I think they got back on track. And then last year, we were in Italy.
We were in Milano for ESA there. And actually, we were on GE, the booth for GE last year
at
as
the
well.
launch of one of their amazing products. And actually, I think we've got a version of it. You can't, it's just not great radio, me holding up to...
Let me get a picture of that, Monty. I'm going to get a picture.
But
here we go.
Here we are with the team.
That's right. We got it.
Yeah.
Yeah, perfect.
And that's part of what we're going to be hearing about is more remote monitoring. And we actually were there at one of the launch of one of the products last year.
The launch of Portrait Mobile. Well, we wanted to catch up with the GE team again this year and hear more about where they've been this last year, what's happening, what's new and upcoming. We see a lot of new products on the stand here, so super excited about that. So this morning, we have Chris Lawman, the Senior Modality Leader for GE Healthcare. Chris, thank you so much for joining us.
Pleasure to be here, thanks.
Yeah, absolutely. And then we have Peter von Heezik, the Anesthesia Digital Leader for GE.
Correct.
Thank you so much for joining us.
Thank you very much for having me.
Yeah, absolutely. Well,
and an Anesthesia Digital
I know.
Is that
lots to break down there.
Okay, yeah. We'll go into that because I don't know what one of those is.
I would think I would like one of those. May I have one of those, please? Well, gentlemen, it's great to be here with GE. Last year, we were here for the launch of Portrait Mobile. We know that has been a major feat for GE Healthcare, and a lot has happened over the last year. So, Chris, I wanted to start with you and talk to you a little bit about that particular product, but also how that's being integrated into the hospital setting to help improve connectivity. And there's this word that we throw around a lot, interoperability. But I want to know a little bit more about that and how the solutions that you guys have with GE Healthcare, how all that's contributing to interoperability and connectivity.
Okay. It's a bit of a challenge. And I think when we look at it as a whole, we speak with a lot of the other vendors as well. And we've come together as a collective to actually discuss interoperability and connectivity and sort of standardization within the healthcare arena. And it is really challenging because we find that, you look at the NHS right now, they've got this kind of drive around artificial intelligence, the big data, primary care versus secondary care, and having that interconnectivity and be able to have, patients' records available for everybody. But I think one of the main challenges that we see is it's great. Let's talk about AI. Let's talk about big data. But sometimes we have to go back to basics. Yeah. So if you look at 90% of the operating rooms in the UK don't have a network.
Right.
Okay, so actually trying to be able to get that data to be able to use the AI is a challenge.
When you say they don't have a network, do you mean that they don't have the wiring there for the internet?
Absolutely.
Okay.
Absolutely.
Wow.
So in many cases, obviously we need to have a network point in the OR so that we can connect the patient monitoring. So we're getting just those standard demographics coming from the patient, being able to get them into an electronic medical record system, and then being able to, use that sort of data to do a little bit more deep dive, looking at, from a research perspective. But we just can't get the data there. You know,
because when one goes into that environment, I mean, I'm mainly come from the intensive care world, and we happened, where I worked at University College London Hospitals, to have had an electronic health record for quite a long time. I kind of think that everybody has got all those connections, like all our infusion pumps and our ventilators all talk to each other. Do I live in a weird place? Is that not normality?
Not in every case. No, you're absolutely right. So you're right. Where it's easy to put a network in, we'll do it.
Right.
But, you know, there's challenges in terms of the OR specifically because of the environment that it is. It's a clean environment. The only time you can get in there is on an audit day, or they have to shut down theatre. And that's expensive. We know we've got the backlog in the UK in terms of getting that elective care done. We haven't got the time to close down theatres to put the networks in. The infrastructure is old in many cases. You know, so you've got old hospitals in London, for example. You've been there, you know, brick-built, really solid hospitals. And trying to put infrastructure in there is a challenge.
Yeah, that is really... Well, I was just going to say that's really interesting because you just assume, especially with the NHS. I mean, I work in the U.S. There's lots of variability. I'm Vice President of Clinical Quality for North Star Anesthesia. We have over 200 facilities. I'm still surprised that we have paper charting in some of our facilities. I would say that, you know, networking, you wouldn't think that the structure of a building or shutting down an OR would really impede that. You would think everybody would want to be, you know, connected.
Yeah, absolutely. I mean, not so much in the OR, but in other areas around the hospital site. You know, when was the last time you actually went and had an X-ray and somebody gave you a film and you were walking back to the A&E and holding it up to the light to see if you'd actually broken a finger or whatever, you know? That doesn't happen anymore, but we still do it with a 12-lead ECG. We're still printing 12-lead ECGs everywhere when it could be all digital.
Why?
I don't know. I don't know whether it's just an adoption. You know, I think it's that change management that's probably needed in terms of education and getting guys to actually understand the capabilities that we have there.
Because the X-ray thing is a great example, because that seemed to happen fairly quickly and fairly smoothly.
Yeah.
And is that because they changed the X-ray machine from being the camera to it being a
analog
total
to digital?
Is that the switch?
Absolutely. I mean, you're using the DICOM protocol to be able to, you know, take those images. We're able to share those images to wherever they're needed. You're getting information at point of care, point of need. Yeah. But it just seems like with a 12 lead that I don't know whether it's, you know, people just need to pick up a piece of paper and feel it and touch it and actually be able to look at it rather than actually seeing it on a digital screen where you can put your calipers on, you can do your measurements and you can do your interpretation.
No, because once it's digital, you can really deploy it or make it available throughout hospital.
Well, you can let the computers help more.
Exactly.
Most of us are not very good at looking at ECGs.
We're not even talking about AI. We're just
these are
exactly.
Basics.
This is basic stuff.
And this is where we need to go back to basics. Just another brief example is, you know, we're trying to deploy equipment into hospitals and we're trying to utilise the wireless infrastructure.
Yeah.
But when you sit down with the IT department, they have several challenges. You've got to have Wi-Fi in all the areas. Some of the Wi-Fi is, you know, a few years old and not necessarily robust enough to support what we're trying to put on there. Or an IT department will be really reluctant to put real-time patient data on their network because of the instabilities, you know, so that can provide another challenge.
The security risk is a huge thing.
Security risk, but that is also the performance and having the data available all the time. It's like having your Wi-Fi in your own house back home and then expect that you will have the same quality Wi-Fi at the attic or the basement of your house.
Yeah.
Is Wi-Fi the answer, though? Isn't it? Or would it be better off just being hardwired, or am I being a bit old-fashioned about that?
Well, you mentioned earlier about Portrait Mobile.
Yeah.
Okay.
Yeah, let's talk about it. You're holding this up right now. I'm going to get another picture.
Holding up something that looks like a mobile phone.
It does.
A hint fatter than some of the modern ones, but very elegant. And you're holding the other hand something that's about the size of an old pacemaker with what's looked like an oximeter probe on it and a wristband. So a very elegant combo of two things.
It is. And a part of this probe is a battery.
Okay.
And within this battery, we have a protocol that's called Binder.
Right.
Which is for medical body area networks.
Right.
Okay, so we're used to talking about Wi-Fi networks. We're used to talking about Bluetooth or Zigbee or other communication methods. This is a medical body area network with a protocol, as I say, it's called Binder. But what this does, it sends data on 3 different frequencies, 3 different times.
Right.
And therefore, the connectivity method that we have, it's as good as a wire.
So this is the patient's mini hub,
Correct.
is it, sort of thing?
Yeah, so because it's as good as a wire, we've got that reliability.
Yeah.
We're not going to be susceptible to interference around the hospital environment. There's a lot of noise, and when I talk about noise, I'm talking radio frequency noise.
Yes.
Not the noise that we can hear, not the ambient noise that we've got going on behind us right now, but it's actually RF. It's hidden, you know?
What's it called again? It's called...
Binder.
Binder
Is the protocol that GE have developed.
And that's, if I'm thinking in simple lay terms, that's your alternative to Bluetooth, but it's
100 times more robust.
exactly.
Yep.
But that's the idea. It's,
Yep,
it's a communicating
Correct.
thing, but the patient wears this so they communicate from them.
And it gives
what's
them
there.
that flexibility to be...
Right, problem solved. Let's
you
get
know,
on with it.
I know.
They're there to be mobile, they're ambulatory, you know, that's going to aid in recovery. So you're not tethered to a bed.
Okay.
So one last question from me, because I tend to talk a lot, is that every time I've been to the IT department with anything new and novel that's a solution like this, they seem to have a problem committee, and it doesn't take them long to find a problem. So they have problem experts, and they usually start with the problem with that is.
Yep.
Okay, so what barriers have you come up against so far with that one?
To be fair, because it's not something, because this is the binder protocol is literally between the sensor and the hub, we're not actually putting this on the hospital infrastructure.
Okay.
So those challenges are not always there in this situation.
So it skips internally, and the robustness of the encrypted envelope of the hospital is for them to worry about.
Correct.
You're just skipping data into it.
Yep.
And therefore you think you can't be cyber attacked?
No, I mean, obviously there's always risk out there.
Yeah.
And then when we go onto the hospital wireless infrastructure, then, you know, there is risk in terms of cybersecurity. We have to make sure that our protocols are secure. And that's something that we build into every product.
Yeah. Well, that was going to be my question about this as well. I mean, I'm thinking as a nurse,
Yep.
I'm using Portrait Mobile, and I'm getting my real-time data for all my patients. It's in my pocket. I don't even have to go to this nurse's station. I don't have to be in the ITU. This can be on a regular ward unit.
Correct. Yep.
Fantastic, right? I think last year we talked a lot about how the filters are really good for this to filter out some of that other noise.
Yep.
Patient factors, they're moving around. It's not picking up their pleth. It starts to alarm, so on and so forth. I think that's great, and we can talk more about that. But, you know, the other thing that is a huge burden to me as a nurse is having to chart all the vital signs, you know, either on paper that their blood pressures were this, or that it comes, you know, over into an electronic medical record. Is there a solution for this, that those vitals actually go into the patient record, or how does
Absolutely.
that work?
So we're using standard IHE protocols in terms of being able to export patient
IHE?
data. Integrated health. They're standards that we
It's
have.
a standard thing.
Absolutely, absolutely. So we're taking the data, we're sending that over a server, we're translating it into HL7, which is a
Health
standard
level
language that
Yep,
we're using,
standard.
Health Level 7.
Yep.
And then we're able to get that data into those electronic medical record systems. Yeah. So whether it's Portrait Mobile, whether it's Canvas 1000 in the ITU or in the OR, well, if there's a network, we're able to get that data into the electronic medical record system, and that's when you can then use that system to be able to collate that data and get your early warning scores and things like that. Yeah.
Fantastic. So some limitations when it comes to networks and things like that, but this really sounds like it can help me as a nurse, Monty as a physician, to have data at your fingertips.
Yeah. And it's going to get better, going to get easier, because we're going to integrate this into other patient monitors.
Yeah.
Okay, so
Very
like I
cool.
say,
Yeah.
keep an eye on that one.
Yeah, we will. Well, Peter, you're the anesthesia and respiratory care, right, digital person. So tell us, you know, all this conversation, I'm sure, is near and dear to you, and you've probably had a lot of a lot of influence in this space.
For sure. So what was explained by Chris is really the monitoring side and making sure that the connectivity, the wireless connectivity is as high quality as possible. I think you were explaining the connectivity in the ICU as well as the operating room, and we're very much relying on the network connectivity. So what Chris was explaining is that when there is no network infrastructure available, then obviously you cannot deploy this data as we would like to offer it. The part we're offering is really the analytics part. So gathering data in its high fidelity. So it's like comparing with a camera of 10 years ago. If you would like to see what's happening in the background of you zoom in today with the high fidelity image. We do the same thing with our devices. So big data. We send all the data every breath. So 500 data points every breath from both the anesthesia machine as well as from the patient monitor, and allow clinicians and managers to analyze their processes, whether it's to do with low flow anesthesia, whether it's to do with the actual use of the anesthetic agents, or whether we're talking about lung protective ventilation part there.
Yeah. Go ahead, Monty.
I mean, we already have a lot of data to, if you just look at regular charted data, we're a bit overwhelmed already. That sounds like super overwhelming, but I'm guessing it's not. So I've seen some analytics and some ways of presenting the data that says, thank you.
You're spot on. Yeah. I think offering more data is not the answer to the question. It's really providing ready-made analytics. It's okay. If you're focusing on outcomes on, for instance, sustainability or on the lung protective ventilation, then having a ready-made dashboard which does not take any IT involvement or processing and just drawing conclusions.
Because you were mentioning, because you were doing a display to Desiree yesterday about some of the outputs, very cool graphics, etc. Mm-hmm. There's a lot of discussion in the anaesthetic community. There's a lot about it here, about anaesthetic vapors, for example, and its negative contribution to global warming and the choice of agent and vapor versus TIVA. But in the first instance, and I think we probably got there a little bit earlier in Europe, we could just turn them down, couldn't we? We could just turn those... We could just actually use lower flows and harvest some of the vapors. Is that one of the drivers of that component of it?
Correct. So low flow anesthesia has been around for a long time. We can clearly see a various level of adoptions of actually low flow being at the minimum flow, half a liter or even less fresh gas flow. In a circle system, that is still high enough to provide more oxygen than the patient is absorbing. But that's really helping out and giving that visibility on whether you use sevofurane, desfurane, isofurane or nitrous oxide, and what the impact is both on the cost as well as the emissions. So by having such a longitudinal view in a dashboard, it really helps to visualize where were you a month ago, what do you want to target for, and how.
So Desiree, back to you as you had a chance to look at that and think about that yesterday as a vice president for quality for a very large anaesthesia group, something that's not far off the size of the National Health Service. What would you do with that data?
It's interesting. The models in the U.S. are slightly different. Our anesthesia groups are usually contracted with the hospital, so we don't always get this data. We're not always for sure exactly what, we don't see the analytics side of this, like how much the flows are and things like that. I started thinking about, we had a big push on Earth Day, about using less gas, about changing your flows, reducing your flows. I think having that data in our hands, we can just target, more efficiently. Where are we using more, and what type of gases are we using, and what is the efficiency of the machines that we're using? Being able to have that data to go back to our hospital partners to say, hey, let's work together in costs. I'm not paying for the gas myself. That's coming out of the hospital budget. Right. How do we work together to improve cost savings? How do we improve the environment, and make that together? So I think just having that data and being able to see it in a way that I can understand as team anesthesia and that the hospital can understand as care providers, but also good stewards and, financial stewards of the organization.
I'm sorry, big data is absolutely brilliant.
Yeah.
But it's got to be tangible.
Yeah.
You've got to be able to read it, and it's got to have meaning, and you've got to be able to use it to your advantage,
Yeah.
We can all store loads and loads of data, but it's useless unless it's tangible.
Well, I think you were showing me yesterday, too, you could even look into the rooms, OR 12, and, we can say, well, so-and-so was in OR 12 yesterday, and maybe we need to have a conversation with them about, their practice. What is the solution name of that product that you're showing us?
The overall solution is Care Station Insights.
Okay.
And obviously the individual applications, so it's an app, you can run it on your phone and you can view it on your computer, are for agents, the agent dashboard, lung protective ventilation dashboard, adequacy of anesthesia. So it's containerized apps, so you don't deploy and you don't show all the blob of all the data, but rather focus, this is the theme which is addressing.
So I hate to bring you back to my committee of problem experts now, and I know we have a tendency to ask these questions, which must sometimes feel insulting because you think, well, of course we thought about the problems and of course we've thought about the solution. We're not that stupid. but we have to ask anyway.
Right.
You know, the immediate things they probably say is, well, you're now walking around with a phone with patients' information on it. You know, that would be one side of it. And the second side of it would be, well, if I've got low saturations on a phone in my pocket and I'm not looking at it, and I'm the responsible officer on the floor, where's the culpability lie there? Who's getting sued? You know, that. So I know that would have been common discussions.
Right.
So those 2 points. I know you can't necessarily address the second one, but Desiree might have to.
No, so coming back to the second one first, because when a low saturation is actually happening on Care Assistance Live, you actually can have this in your pocket.
Yeah.
But the notification will buzz, or the tone will definitely ring when that alarm is ringing into your operating room, the one you're responsible for. That's clearly helping on focusing on these patients.
You know, I'm walking around here and I accidentally put my phone. I've got an example's just been called up for me here, which has got all the rooms on it, and everything's looking pretty good. Not sure about the SATs in that room and the heart rate. We can go and have a chat with them in a second. But if this, you know, let's imagine this had patient identifiers on it and I put it down. I've now done a HIPAA breach, I think. But I don't see any names on here.
Exactly. So the question you raised is something we did consider. There's no identifiers on the app itself. So no patient identifier nor the physician that's responsible for that operating room. So as a physician, you know that you're responsible for operating room 1 and 2 and 3. Those are the ones you activate on your app. So you will receive those notifications for those 3 patients.
So whoever's in OR3, we need to go and have a chat, Desiree.
Yeah.
Don't we think about that?
I know. Ooh, that's bad.
You have OR3.
I know.
OR3, we're coming to you next. Okay.
So you've deployed this now for some time. How's it going? Some good feedback on that.
It's going well. We initially introduced our Care Assistance Live app on the iPhone. And we could clearly see that when discussing with the IT departments of hospitals, that some hospitals really standardized on Android. So we, in the meantime, now launched the Android version and implemented this Android version, because the initial idea of the hospital said, okay, let's invest in iPhones for those anesthesiologists, but they were carrying the Android of the hospital. They had their own private iPhone, and they were planning to carry the third phone. So you can imagine that how successful this would be.
And the first thing they did in COVID is take them all off us. If you see. The infection control police came round, put them all in a, it's my phone.
No.
Took them away, said you can't have those now. So,
So from an implementation perspective, those are other elements which we initially did not think would be an issue or challenge. But like having network infrastructure available, this is the other one that is overcome now.
So I'm holding up your own device here in my hand as opposed to looking at my own phone, if you see what I mean. Why not stick it all on this then, if you see what I mean? So it becomes like my pager, my bleep, my clearly hospital device. I'm not taking that out to the pub to text my kids on, if you see what I mean. That's clearly hospital kit.
Right,
so.
right. The way it works on the phone is that it's really relying on the hospital network. Okay. So as soon as you move out of the hospital, you don't need to have your notifications from the OR3, because if you're on holiday in Glasgow.
You should talk to your company about that. They don't see it that way, do they?
They've been very good about my PTO. So one last question, gentlemen. Again, thank you so much for sitting down with us. I think it's so important to have these conversations, to hear more from the voices of those who are developing these solutions for us, and how do we actually deploy those and use those as providers. So one of the big themes here at the meeting this year and for USG Healthcare is patient safety. And, how do we improve patient outcomes with the solutions that you have? So just kind of wrapping up, let's tie it all back to that. Like, how do you think, Portrait Mobile, Care Insights, all these different solutions that you have are really going to make it safer for our patients? Chris?
70% of patients in the hospital are unmonitored. Okay. So obviously that's a massive amount, and most of the cardiac arrests happen outside of the high acuity arena. So by putting on wearable sensors, by measuring just whether it's respiratory rate or the SpO2 rate consistently across the board, we've got an eye on that patient. We can detect early deterioration of a patient, and we can interact before there's any, reason to take that patient back into a high acuity area. And this is the story that we're trying to work on, because people get it, but they're not doing anything about it. Yeah, so we're really focusing a lot in getting the story out there, making everybody aware of those issues. I don't have a clinical background, okay, but speaking with people, doing the voice of the customer and understanding everything, we know that the 30 days post-operative is that key area, especially for post-operative respiratory depression or whatever. So just by putting that resp sensor on, even if it's for 7 days afterwards, if someone's going into a step down or into a ward space, it's really going to help in terms of that early detection of deterioration of a patient.
Yeah, and I think getting the information, the word out that this actually is easier technology for us nurses and the hospitals to use, because I think there have been previous versions that have been not so great. Mm-hmm. So we're a bit biased whenever some new technology comes up, and we're like, oh God, more alarms.
It's a really good point, because bringing in technology into the ward space is probably where the healthcare professionals are not used to using technology. Yeah. When I've been out and spoken to a customer about this solution, we're talking about cloud-based services. Yeah. We're talking a lot about network infrastructure. And we can scare the living daylights out of people.
Yeah,
but actually, when you use it, it makes their life so simple to use.
Oh, yeah.
And that's the key driver for me. People have to see it working and seeing how it's going to benefit them. Yeah. Whereas today, they, like you said earlier, they're just going to think, there's going to be a load of alarms going off. How am I going to manage those alarms? What's the escalation protocol?
Do you or the hospital allow the patient and or their loved ones to see the date? Because we're now used to looking on versions of it on our smartwatches or whatever it is, and it's rare to bump into somebody who can't tell you their steps and heart rate now.
Yeah, exactly.
So I can imagine as a patient suddenly being confused as to why I can't look up my data, and if my mum's there, why I can't look up mum's data. Is that? Yeah, I'm guessing that's not your call. That's the hospital's call, is it?
I guess it is, but I'm holding the hub right now, and this hub would remain with the patient.
Okay.
Okay. So the hub would connect to a Wi-Fi network. There'll be a central patient viewer. So the clinicians can keep an eye on up to 48 patients at any given time, but this hub remains with the patient.
So they can look at it.
Whether they're laying in their room.
So your beloved one can actually look.
Yeah, whether they're laying in their room. Monitor. Yeah. Or whether they're ambulatory, it still sits in their pocket or in a pouch. Okay, so they can still look at it, and we're talking about things like human factors and bringing all that into it. Yeah. So why not in the morning they look at here and there's a traffic light system and they says, how do you feel today?
Yeah.
And it's red, I feel really bad today, or it's green, I'm feeling good. And there's all of that can be brought into it in the future.
Maybe they should tell you before they see the red or the green.
Yeah, absolutely.
Ask the question before they see the colors. Well, I'm thinking there will be a lot more education. So this is the change management.
It's change management, thing. Absolutely.
Not only for the nurses, but for the nurses to patient families, because not everybody understands all that. But what I can see and envision is that because you're going to have more time, there's a lot of burden that is taken off of nurses for this. I actually will be able to do what I was trained to do and why I went into nursing, is patient and family interaction.
The anxiety level is reduced dramatically, whether it be the caregiver, knowing that my patient's being continually monitored, or the patient knowing that they're being continually monitored and not somebody popping in and seeing them every 4 hours. Yeah. So it's really a huge benefit.
Yeah, interesting. Peter?
Yeah, you mentioned improvement of patient care. If you look into our guidelines, we have guidelines in healthcare for a lot of things. And in this case, Care System Insights really help to visualize to the adherence to these guidelines and really help to focus on, this is where there's room for improvement, and this is where we can further enhance outcomes, because the guidelines are developed to drive these more standardized outcomes and predictable outcomes. And if you look into the sustainability part, it obviously shown that saving costs and saving the planet and improving care quality really can go hand in hand.
Yeah, absolutely. Gentlemen, this has been a fascinating conversation. Thank you so much for taking the time out. Thank you so much for listening to TopMedTalk here at the Euroanesthesia 2023 meeting, the annual Congress of the European Society of Anaesthesiology and Intensive Care. Got to get it. Here in Glasgow, Scotland. We'll be here over the next several days. Please do check out all of our other wonderful conversations. Monty?
See you all soon.
Thanks. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.